Hi, everyone. My name is Lydia Gedmintis. I'm a rheumatologist at Brigham and Women's Hospital, and I'll be talking now about rheumatoid arthritis, both the diagnosis and how to diagnose it, as well as new treatments. I have nothing to disclose today. So just to bring you through what we'll be talking about during this lecture, we'll talk a little bit about the definition of rheumatoid arthritis, as well as its diagnosis. And we'll spend some time talking about the different treatments for rheumatoid arthritis, particularly what to do before starting therapy. We'll go through the major treatment categories and their benefits and risks, and also what to do if a patient on immunosuppressives gets sick. And we'll have a couple of board-style questions at the end as well. So what is rheumatoid arthritis? I'm sure that you have all seen patients with rheumatoid arthritis in your practices, but it is a inflammatory arthritis that primarily is symmetric and affecting the small joints. The classic example is somebody who's coming in with hand and foot pain. And in the hands, classically, rheumatoid arthritis likes to affect the MCP joints over here, as well as the PIP joints over here. So on somebody's exam, you oftentimes see swelling at these locations. And in somebody who's had long-standing rheumatoid arthritis, what we can see eventually is damage to the joints as well. So here you can see examples of erosions, which are sort of these bite marks taken out of the bones themselves. And as rheumatologists, we do not like to see these x-rays, and this is what we're trying to avoid with treatments. So in terms of diagnosis, I think most of us think classically about the ACR criteria for diagnosis pre-2010. And this is when you have 4 or more of the following criteria, including morning stiffness that lasts more than an hour, arthritis of 3 or more joints, arthritis particularly of the hand joints, that the MCPs, PIPs, and wrists are classic involvement, symmetric swelling, serum rheumatoid factor, and radiographic changes. And they suggest that the first 4 must be present for greater than 6 weeks. But since 2010, there's been some updates with that, and the classification criteria were redefined at that point. The reason they were redefined is that we wanted to capture patients a little bit earlier. So patients with synovitis of at least one joint that has no other explanation is when we suggest patients to be tested. There's sort of a new point system where 6 or more points out of 10 were required to make the diagnosis. And the points now are given based on the number of joints involved, the serologies. Now, not only the rheumatoid factor, but also the CCP, which we use frequently in our rheumatology practices. Acute phase reactants, including ESR and CRP, as well as the duration of symptoms. So in terms of a characteristic exam, you can just sort of think about that first picture that we started the lecture with. A symmetric synovitis and small joint involvement is the most common. You can have patients who present with, a knee or a hip, but classically we think about small joint symmetric synovitis. Now, joints including the cervical spine can be involved, but the lumbar sacral spine is generally spared. Another area that is oftentimes spared is the DIP joints. So if somebody has involvement primarily of DIP, you may want to think about another type of inflammatory arthritis. In terms of extra-articular involvement, this is generally seen with seropositive patients, especially those who have severe or long-standing disease. But patients with RA can have lung involvement, and this manifests itself as interstitial lung disease. They can have cardiovascular involvement, rarely something like vasculitis developing or pericarditis, and rheumatoid arthritis is also associated with coronary artery disease, which we'll talk about in a little bit. In terms of the skin involvement, you can develop rheumatoid nodules, which again is generally occurring in patients who have seropositive and long-standing disease. In terms of characteristic lab findings, we oftentimes consider elevated inflammatory markers such as ESR and CRP, and positive serology. So everybody knows about the rheumatoid factor. It's positive in about 70 to 80% of RA patients. But the CCP is also something that should be checked if you're concerned about rheumatoid arthritis, as it has a very high specificity for RA. The CBC can be abnormal with an anemia. Generally, an anemia of chronic disease is what we can see. Felty syndrome is uncommon. It's generally seen in, again, patients who have severe seropositive RA, but it is a syndrome of neutropenia and splenomegaly as well. If a joint is aspirated, the inflammatory fluid should be greater than 2,000 of white blood cells or an inflammatory fluid. In terms of characteristic imaging, I reviewed sort of this X-ray, which classic changes of RA would show erosions or periarticular osteopenia. But the important thing to note here is that these changes are not generally seen for at least 3 months of somebody having active disease. So it's useful for diagnosis after 3 months, and it's also helpful for staging. But it is not useful to check when somebody is presenting with joint pain for, say, 3 or 4 weeks. And MRI and ultrasound are being increasingly used in rheumatology practices to help with confirmation of synovitis if it's not evident on exam. MRIs and ultrasounds are really great for looking at synovitis and tenosynovitis within joints. So when to initiate treatment? Basically, the answer is as soon as you make the diagnosis. Early treatment has been linked to better outcomes for patients, including reduced surgeries, reduced evidence of joint damage on imaging, and better chance of remission. There is concern that treatment of RA can also improve life expectancy as well. So here is a study that was performed in a nurse's health study. If you look here, you can see this gray line is non-RA patients, and this blue line is generally sort of our more severe patients who are seropositive. We think that the decreased life expectancy in rheumatoid arthritis is possibly due to the increased risk of cardiovascular disease, at least in part. And we found in studies that treatment of their RA may substantially improve life expectancy, possibly by at least in part reducing this cardiovascular disease risk. So what to ensure your patient has before starting immunosuppressive therapy? Ideally, you check a CBC, LFTs, and creatinine. You check a chest X-ray if you are considering treatment in an older patient or a smoker, particularly if starting methotrexate, and we'll talk about why in a bit later. Infectious screening is important as well, so checking either a PPD or a T-spot, quantiferon gold, and checking a baseline hepatitis panel, as well as making sure patients are up to date with their vaccines. So getting a yearly influenza shot. Pneumonia vaccines are important even if the patient is younger than 60. And if they're over the age of 50, non-live recombinant shingles vaccine or Shingrix is important. Live vaccines are generally contraindicated for patients who are on immunosuppressive therapy. If a patient requires to have a live vaccine and you are considering starting immunosuppressive therapy, you should give the live vaccine now, and then you'd have to wait up to 2 months before you start an immunosuppressive therapy. And then the question is sort of what immunosuppressive therapy to initiate. So just in sort of broad strokes, you want to consider things like steroids, synthetic disease modifying anti-rheumatic drugs, which is a mouthful, so we'll call it DMARDs during this talk here, and biologic therapy as well. So this is a 2015 guideline from the ACR in terms of thinking about treatments for rheumatoid arthritis. And right here, they're saying in somebody who has never seen a DMARD before, and has early RA, that generally you think about starting DMARD monotherapy first. And if they're still progressing, still have moderate or high disease activity, that's when you consider using a combination of either traditional DMARDs or considering adding on a biologic therapy. So just to sort of step back a little bit about steroids, and can they be used as sort of a disease-modifying therapy? As you guys know well in your practices, steroids are sort of our best friend and worst enemy. They can help to quickly decrease inflammation and even halt progression of disease, and they can, i.e. sort of acting like a DMARD therapy in rheumatoid arthritis. But the issues are that the risks of steroids and the long-term side effect of steroids only as a therapy for RA likely outweigh the benefit. So the way we use steroids in our rheumatology practices are generally to sort of use it as a bridging therapy. So starting it initially to help patients feel better quickly, but then sort of weaning that off as we start DMARD therapy. So synthetic DMARD therapies include hydroxychloroquine. It's overall very well tolerated, but does have potential side effects. So commonly, we can see sort of gastrointestinal discomfort, sometimes a rash. Very rarely, although this has been in the news more often recently, we can see myopathies, cardiac conduction abnormalities, and again, rarely ocular toxicity. So patients on hydroxychloroquine require an eye exam about every 6 to 12 months. We generally think about starting with something like hydroxychloroquine when the patient's joint pain is very mild, and that would be sort of a good starting place. Sulfasalazine is another synthetic DMARD that oftentimes these days is generally used as part of triple therapy for RA, which I'll talk about in a little bit. The potential side effects of sulfasalazine include gastrointestinal toxicity or discomfort, hematologic toxicities, and hypersensitivity reactions. Now, the synthetic DMARD that really changed the face of RA treatment was methotrexate. And so in the 80s, this was found to be incredibly helpful for rheumatoid arthritis. It's been, it's changed sort of the natural history of RA, it's decreased extra-articular manifestations, and it's increased quality of life and even potentially survival. It does have its own set of risks or potential toxicities. So most commonly, it can cause sort of nausea or discomfort, GI discomfort, oftentimes the day after taking the medication because it's a once-weekly medication. We try to prevent that by using folic acid as a supplement in addition to the methotrexate. You can develop liver and hematologic abnormalities, so we generally check lab work about every 3 months or so once they're on stable therapy to monitor for this. We also ask patients to stay away from alcohol just because of this concern for liver abnormalities. As with a lot of our DMARDs and biologic therapies, there is a potential risk of opportunistic infections. So, when we start thinking about starting these medications, we want to make sure patients are appropriately vaccinated and screened. They can have an effect on reproduction. They can be potentially teratogenic and also have an effect on the sperm as well. And rarely it can affect the lung. So sometimes in the first year of treatment, patients can develop an ILD-like picture. Again, this is very rare, but something to monitor in somebody who's recently started methotrexate and having new pulmonary complaints. It can be rarely nephrotoxic. So we do check a BMP or basic metabolic panel in addition to liver and CBC tests about every 3 months. There's a concern for possible malignancy that has popped up in prior studies. We have not seen this pan out in long-term studies. Leflunomide is a medication similar to methotrexate. It has a simpler dosing schedule. It has a quicker onset of action, which makes it attractive to a lot of people when they're considering starting synthetic DMARD therapy. And again, it has a similar side effect profile to methotrexate. So one reason to really think about not using it would be that it is teratogenic with a long half-life. So we do avoid this medication in women of childbearing age, in which case, we'd want to think about an alternate treatment. And what if a DMARD is not enough? So, say we start a patient on methotrexate and they improve, but they just haven't gotten as far as we'd like to be. So the options here include something like triple therapy, which includes methotrexate, sulfasalazine, and hydroxychloroquine, basically 3 of our synthetic DMARDs, as well as either transition to or adding a biologic. Now, how to make that decision is a tough one and something that rheumatologists often struggle with. Both of these therapies, either using triple therapy or adding or transitioning to a biologic, work well. Disease progression is similar, although possibly less radiographic progression with biologics. So that is something to sort of keep in mind. When we talk to our patients about the next step, we want to take into consideration the side effects, patient adherence, and cost. Triple therapy can be complicated for some patients as you're taking 3 different medications with potential side effects. And also just in terms of timing of when to take it every day. But biologics are also extremely expensive, as you know. So it's sort of a talk that we need to have with each individual patient. Now, in terms of biologic therapies as of 2020, these are the general groups that we think about. Anti-TNFs are likely the most widely known. These include etanercept, adalimumab, and infliximab. IL-1 receptor antagonists are on the list of general categories. This includes a medication called anakinra. However, it's not commonly used for rheumatoid arthritis, as it has not been proven to be very effective in large studies. Co-stimulatory blockers, such as abatacept, are frequently used. B-cell depletion, as in rituximab, is frequently used as well. IL-6 receptor antagonists are increasingly used, including tocilizumab and sarilumab. And JAK inhibitors are sort of the new kids on the block. And these include tofacitinib, baricitinib, and upadacitinib. So going back to anti-TNF therapy, they all have about similar side effects. Again, there's several medications in this group. They all roughly have a response rate of about 60 to 70%. They work well in early disease and late disease, but the outcomes may be a little bit better in early disease. They stabilize radiographic progression. With use, you're able to sort of decrease NSAIDs, steroids, and methotrexate doses. And they have been shown to induce remission in some studies upon withdrawal. In terms of adverse events with use of anti-TNF therapy, injection site reactions are probably the most common side effects that we see, and we can talk through with a patient how to manage these. Diffuse rashes can rarely be seen. As with some of our synthetic DMARDs as well, we do want to be concerned about increased risk of infections. So you can see things like sepsis, septic joints, pneumococcal infections. Again, as with all the biologic therapies, we want to make sure that patients are vaccinated and screened appropriately before starting these medications. From a cardiac perspective, we are wary to use these in patients who have who have congestive heart failure. So there's an increased risk of worsening heart failure in patients who are class 3 or 4 CHF. There is a very rare chance of demyelinating diseases with anti-TNF therapy, so we avoid use in patients who have first-degree relatives of diseases such as MS. Anti-TNFs, when they were first started to be used, there was an initial concern for increased lymphoma risk. In the setting of their widespread use, there have been large studies that have been performed over the years that have shown that lymphoma is not shown to be at increased risk. However, there are possible increased risk of skin cancer. So what we do recommend for patients who are starting anti-TNF therapy is to be seen by a dermatologist at least yearly for a skin check. Abatacept is another medication that we use for rheumatoid arthritis. It blocks T-cell coactivation pathway. It has similar risk profile to anti-TNF, but less of a concern for tuberculosis risk. So this may be something to think about, for instance, in somebody who travels frequently for work. May be used with or without methotrexate. We generally consider abatacept and most of the other biologics that I'll be talking about after a TNF failure. In this case, the response rate is about 50% after an initial TNF failure. The onset is a little bit longer than some of our other medications. It takes 4 to 16 weeks to actually kick in. Rituximab is another medication that you probably mostly know from the oncologic world. It works by B-cell depletion. We use it in the rheumatology world, mainly in seropositive patients. It's shown to work best in this subgroup. The adverse side effects include infections, including PML, hepatitis B. We do ensure, especially with rituximab, that a hepatitis panel is checked prior to starting and updated frequently. You can develop rashes, including psoriasis. You can develop low cell counts, including white blood cell count. And also you can develop a low IgG for long durations, even after stopping therapy. And this is of unclear significance as to whether this continues to lower your or increase your risk of infection. IL-6 inhibition is also an important tool that we have in our arsenal to fight against inflammation and RA. Tocilizumab is a monoclonal antibody that blocks IL-6 receptor. It works quickly, which is sort of the nice thing about it. Its onset is a little bit faster at 2 to 12 weeks. And it has impressive improvements in CRP, quality of life, and fatigue. Again, with the biologics, we worry about increased risk of infection, so you need to monitor closely. There is a potential increased risk of GI perforation in patients, particularly in those who have a history of diverticulitis. So we always ask about this history before starting the medication. We do monitor lipid, leukocyte, and liver tests frequently because we can see abnormalities with tocilizumab. So sarilumab is another medication that deals with IL-6 inhibition that has been recently approved and that we are starting to use in our arsenals as well. JAK inhibitor therapy is another class of medications that we have been starting to use it increasingly. Tofacitinib is a first oral biologic, so that has been attractive to some of our patients who want to avoid the needle, understandably. Baricitinib and upadacitinib has recently been approved as well for use in RA. Potential complications, again, include infections, but in particular here, we see an increased risk of zoster. So it's important to consider vaccination before starting JAK inhibitor therapy. Again, lipid abnormalities have been reported. Neutropenia, anemia, and LFT abnormalities have also been seen, so we do check these frequently when patients are on JAK inhibitors. We can at times see an increased serum creatinine, so we check a BNP. And also, as with some of our biologics, there's initial concern for potential increased risk of malignancies, although we haven't seen this in long-term studies. So what to do when a patient with RA on therapy calls with a fever? This is especially important in the era of COVID too, so to kind of keep this in mind now in this new world. If somebody calls you with a fever or if they're otherwise feeling ill, we do recommend stopping the methotrexate or biologic therapy. If a patient is on hydroxychloroquine, that is generally okay to continue, but in particular methotrexate or biologic or another DMARD or biologics, we would stop if a patient is ill. We do ask you to have the patient come into the clinic to be assessed, and we would consider further workup and treatment, such as chest x-ray or antibiotics, sooner than you would with an otherwise healthy patient, just because these patients are at increased risk. And again, in the era of COVID, we would definitely recommend getting these patients in for testing as soon as possible. So in summary, rheumatoid arthritis is a treatable disease, and early treatment is key. And we see less joint replacements, improved morbidity, and even mortality with early treatment. We would love your help in ensuring a patient is up to date with monitoring and vaccines while on therapy. And there are a growing number of options of treatment, and it seems like it's growing every day. So if you have any questions about this in general, just feel free to reach out to your rheumatologist to talk about some of these treatments if you have any concerns. So just to switch here to our board questions. The first question is a 58-year-old male who presents with polyarticular pain that has lasted for about 6 weeks. He's had fevers and weight loss and has a history of traveling to Cape Cod and Martha's Vineyard. He has morning stiffness as well as shoulder, hip, and MCP pain. And he has a normal physical exam except for MCP pain and palm palpation and a small right knee effusion. So all of this should be part of the initial diagnostic workup, except A, chest x-ray and hand and foot films, B, Lyme titer and ANA, C, rheumatoid factor and anti-CCP, D, a diagnostic tap of the knee, or E, ESR and CRP. So the answer here is A, chest x-ray and hand and foot films. So while it's not wrong to obtain a chest x-ray, and in fact, we may want to do it when deciding drug therapy, particularly if we're considering something like methotrexate, it is not essential for diagnosis. And hand and foot films are unlikely to reveal anything significant after only 6 weeks of symptoms. Question 2 is a 48-year-old man who's presenting with rheumatoid arthritis. He's deciding which DMARDs to take next. He has erosive disease and has a history of travel to Russia and Peru and has a vague sulfa allergy. His labs are unremarkable except for creatinine of 1.7 and an AST of 58. All of the tests should be done before deciding the next therapy except A, a chest x-ray, B, a PPD, C, pneumonia vaccine, D, hepatitis panel, or E, an ACE level and an SPEP. So the answer here is E, an ACE level or an SPEP. An ACE level at this point would not be helpful in the diagnosis of rheumatoid arthritis, and an SPEP, while it is always interesting, is not particularly needed at this juncture. And that is the end of our lecture today. Please let us know if you have any questions.